Okay, I guess we're going to get started. My name is Chantel Antone, so I'm going to be facilitating the workshop today. I'm not going to use the microphone because I already have a loud voice anyway, so I think I'd be too amplified. But I'm just going to hand out a couple folders here with some information. And the majority of the information is also in the PowerPoint too that I think is going to be posted on our website. But you're more than welcome to email me and I will provide you with a copy of today's presentation. So a little bit about myself. I'm from the First Nation community, which is located just about, I don't know, it's about an hour, 2 hours from here in the Southwest Middlesex region. My community's name is the United Nation of the Thames. We're from the cultural group, I guess it would be kind of like a overarching group, which is the Haudenosaunee First Nations. You may be familiar with the Six Nations Confederacy. So our tribe falls underneath that. My clinical background, I come from long-term care. I worked there for about a year. I've been nursing for about 6 years. And after I did some long-term care work, I decided that I wanted to, I guess, kind of move on to something different. And I started working as a project coordinator for the Windsor Regional Hospital for a First Nations project that the University of Windsor was conducting with the First Nations communities in the Erie St. Clair LHIN. This position came up, so then I thought, well, it was in my area, so I applied for the Southwest Navigator for, I'm housed out of, I guess, somewhat LHSC. We have a home base where my office is across the street. So I've been in my role now for about almost 2 years. So my palliative care background is really only about 2 years, give a little bit. And so I'm kind of brand new to the world. With my cultural history and our cultural background, though, I think palliative care has always been a part of our everyday life. It's not really something that we thought was a clinical role. It was always just something that was part of our traditions and what we did to care for our people. And what I found in my role was that palliative care was really a term that we didn't really associate with, and we didn't really know what it meant. So that's just kind of a little bit about me and kind of like where I come from. So this is a quick overview of how I'm going to start I guess, go into the rest of the presentation. So when I started in this role about almost 2 years ago, my very first patient was a head and neck cancer patient. He was 55 years old. He was from a very traditional family, meaning that they practiced their language, they practiced their traditional ceremonies, they attended longhouse. He came from a very large family. His family is probably from about 300 people. He comes from brothers and sisters of about 17. So when he became sick, a lot of the family members all took on the role of the care provider. He did go do, he did head and neck surgery, so he had, I don't know the correct terminology for it, but he, I think they removed a bunch of the lymph nodes in his neck, and it was, to me, it was probably the most horrific thing that I've ever seen. It was like, and this is how I'll just describe it, and I'll be very straightforward and I'll be very blunt. It was like a horror movie when Freddy Krueger literally slashes somebody's neck open, and all of their neck and all of their veins and all of their muscles and all of their flesh is really just left out in the open. Because I'm new to the role, I didn't know if this was normal practice. So we just took it, we just went with, rolled with it. So when he came home, he did attempt to do chemo and radiation, which he only initiated just, maybe a couple treatments in, and his body couldn't tolerate it. So he literally just said, no, I'm not doing anything else. Just let me go home, let me be with my family. So I would have in the evening, because all of our communities are very close in proximity to each other. So in the evening, sometimes when he would come home, he would be literally like leaking out fluid from his neck. He did have nursing coming in twice a day to do dressing changes. And so the family would call me, because I knew the family as well. They're, I've grown up with the whole entire family. And so they would call me and say, oh my God, Chantel, like what's going on here? His neck is like literally, you know, there's like fluid all over the place. So I would, whatever stock I had of my supplies, I would, you know, say, come over, can you pick it up and take it over to him? He did, as time went on, he just remained in the home. His primary caregiver was his niece. She has no clinical background whatsoever. She was a young girl. She literally took the time off of work. So I don't know really too much of the logistics about what she did, but I know she was off work for a good period of time to care for him. So her and I became, we had this connection, I guess, because I was going to see him almost every day just to make sure that, you know, his pain was under control. He did have nursing, like I mentioned, twice a day. The way his pain medication was being administered when in the home was through 10 mil injections. So he literally had a cup on the table with his morphine in little vials, and he was just, you know, just squirting them in his mouth. And the niece is the one who would drop the medication for him. She has no clinical background. And when I came on the scene, I was like, oh my God, like I could not believe kind of that this is what was happening. So my first kind of, you know, intuition was kind of like, well, you need to keep a log. We need to keep track of what his pain medication is. We need to, you know, just monitor it because there's people coming in and out of the home. We don't know if he's getting his meds or that sort of thing. So the family began to keep a log. And then as time went on, this was probably over a period of, I think he had surgery in, I don't say January. I came on the scene the end of February, so it's 2 months in. They were managing quite well considering the situation that the fellow was in. And so as time went on, he started to deteriorate because he obviously wasn't getting any more treatment. And caregiver burden became to be, you know, that was, the niece was just, you know, she was under a great amount of stress and anxiety. She did become we did talk about power of attorney with her, which is also a new term or an unfamiliar term, I guess, with a lot of the community members that I work with. A do not resuscitate was put in place a little bit later. Again, that's an unfamiliar term with a lot of our community members. And then eventually it led to discussing the Edith. So they did institute Edith in the home. So he remained in the home as he began to deteriorate. I was brand new again. I was kind of unfamiliar with the PPS scores and that sort of thing. So communication was always kind of like a barrier or a challenge between healthcare providers. And the way that I kind of describe it, I seen him, like this was kind of when things really took a deep spiral downhill. It was I believe it was a Friday afternoon. We went in for a consult with one of the oncologists. And he was still walking, he was still ambulating, he was still eating, he was still drinking, he was still smoking. And so we left the hospital that day around 1 o'clock, returned home. You know, always my communication with the family was call me if you need me, if anything comes up. 4:30, 5 o'clock rolled around on a Friday, and his PPS, now that I know, I was familiar with it now, I wasn't then, but I would say that he was probably operating at about 80 on that Friday, 70 to 80. And then by the time the afternoon rolled around, like say the 4:30, 5 o'clock, he was probably down to 30. He was just literally sitting on the couch, not talking. He wasn't coherent. He wasn't eating, he wasn't drinking, he wasn't doing anything, he wasn't ambulating. And I think he even fell at one point. So in the communities, there are home and community care programs that help to implement services for PSW. They have nurses that will come in and do home visits with their patients, more for updates and just making sure that services are being implemented. And one thing that I did find out, and we'll get to this a little bit later in the presentation, is that I didn't know this, but the home and community care programs for the First Nations communities have not received any increased funding since 1999. And that was part of a research project that was undertaken by Lakehead University. I'll get into it a little bit more, but it does relate to here as well, because one of the things that we found as we were trying to, you know, manage him in the home was, you know, PSW service, who's going to wash him, who's going to take care of him, who's going to, you know, toilet him. He didn't have a commode. He did have a hospital bed, so he was literally, the family was literally like carrying him around from the bed to the bathroom. They were all like lifting him up themselves, and people would go in and wash him and that sort of thing. But when I think back to that now with the new information that I know about the funding, you know, I can kind of see where, you know, those things have been challenges for our communities, that there's no money, or there has been no increased money for services. So then back to his PPS, so it was down to about maybe 30, Friday night, 5 o'clock, main healthcare providers from Monday to Friday, no longer on call, they're not available. New staff was coming on. So we managed through the Friday night. Saturday night came, you know, I was in constant contact with the caregiver, primary caregiver, you know, in constant communication about, you know, how is he breathing, is it labored? These are some of the things that you'll see. So he eventually just kept deteriorating as the days went on. A new nurse came on the following day. She was brand new to palliative care, and bless her heart, you know, she did what she could, just given the circumstances. And I do have to share, because I kind of have to laugh, that because I was so brand new to the role, I had no idea what to do. And so I was on the phone with a bunch of different people saying, what about this, and who do I call, and what about that, and what about pain, and what about PSWs, and what about, you know, shift nursing, does nursing come in at night, or what do we do for this fella? And I finally kind of didn't have any answers from anyone, or not the answers I was looking for, I guess. So then I called Dr. Anita Singh on a Saturday, and I think I had emailed her a number of times on a Saturday. And I think I had even called her on the Sunday as well, and bless her heart, she answered my phone call. And she just kind of, you know, went through the list of items, like do this, call this, and, you know, kind of just went down the kind of the lines of, I guess, contact for certain services. So I thank her very much for that, because now that I think about it, I'm like, oh my God, I would never call the doctor on a Saturday or a Sunday. But I guess that's kind of the work that we do too, right, for hospice palliative care, is that you're almost always available, you know, even though you say you're off the grid, you're not. So eventually, 4 days later, Monday came around, he went without any further pain control other than getting the vials from the cup and, you know, kind of just squirting them in his mouth. Monday came back around, his primary caregiver returned to the scene. She was kind of like, oh my God, what is this? Got on the phone, called everybody that she needed to call, got their orders for medication. He got a pain pump. She got him some, you know, PRNs for anxiety, that sort of thing. And he died on Wednesday. So he finally became probably comfortable on the Monday or the Tuesday, and then he died on the Wednesday. The family was at the bedside throughout the entire ordeal. And just the bottom that I have on there is that you can kind of imagine what he went through from the Friday to the Monday, when he finally got his pain pump and when he finally got some anxiety medication to help him, you know, I guess die in comfort. So the family was at the bedside. They're a very traditional family. They were the people that did take care of his body. So after he passed away, he was taken to the local funeral home, and the family was involved in the care of his body afterwards. I don't know all the specifics of it. I do know that part of some of the traditional ceremonies that we do perform on the body is giving them a cedar bath. The cedar is just representative of cleansing the body and, you know, preparing them to go, you know, to the Creator. They did dress him as well. So they brought, they had clothes made. So he had his ribbon shirt on, and the clothes were actually made by one of the good friends of the family. So she offered and said, I'll make his shirt. So the fellas in the family, I believe it was some nephews and a couple brothers, were part of taking care of him to get him ready for his journey home. So really, I just wanted to share that because I was brand spanking new at the beginning, and I don't know, I guess I needed to really go through that to kind of see and I guess be right beside the patient. So I thought that was just something to share. And I think as time has went on, I've navigated the system, I think, the same way I have as a patient, because I've been right beside them and I've been able to see what they've went through. So I just thought I would share that piece there to start. So this next piece is kind of just more for FYI. Some of us aren't familiar with all of the, what the population base is in Canada and Ontario. So there's just some statistics there and some numbers. And this slide here is really just for the patients. I guess some of the patients that you may deal with, they may refer to themselves as First Nations, Natives, Aboriginals, Indigenous. Some of us have technical terms that were recognized under the federal government. For example, if you're a status Indian, then you're given kind of like what they call a card, and you're given a number, and that's how the federal government identifies First Nations or status Indians. Non-status Indians are ones who have lost their status either through enfranchisement, like back in the war. When our parents went to the war, they had to give up their status as a First Nations person. Therefore, all their children and all their, all their people underneath them lost all their status. Bill C-31s, those are people who are recognized as gaining their status back when they married non-natives. This is more just for, technical purposes, and you can read more about that. And the three groups that are in Canada and Ontario are the First Nations. There's Inuit and Métis, so they're kind of like, I guess, the three main cultural groups. Actually, I think there's 5, but so this kind of goes back to like why an Aboriginal Patient Navigator, and some of these statistics that they've been working with at Cancer Care Ontario in conjunction with our Aboriginal Cancer Control Unit is just identifying that Aboriginal people are, they're having higher mortality rates with cancer. So what we're finding is that people are coming to their cancer journey, late stage cancer, and it's and some of them are coming with cancers that are treatable. So through Cancer Care Ontario, there's an Aboriginal Cancer Control Unit, and through the work that they've been doing with Cancer Care Ontario is the Aboriginal Cancer Strategy, which really is the, I guess, kind of like the roadmap that says this is how we're going to address First Nations, Inuit, and Métis cancer across Ontario. So this is kind of, I guess, like a medicine wheel. A lot of our cultures kind of relate to the medicine wheel. The medicine wheel isn't always something that all the communities are familiar with or that all of them use. It's more just kind of just representative of how a lot of our communities may relate to health. So health is your spiritual, your mental, your emotional, and your physical being. So when sometimes when one of those things are off, then that may be contributed to the illness. So that's just one way that that some communities look at health and well-being. And so for the Aboriginal Cancer Strategy, it really is just to improve the performance of the cancer system for First Nations, Inuit, and Métis people. So this, the support in the Southwest, so I'm the Aboriginal Patient Navigator. I work alongside Dr. Rugden Hill. I don't know where his picture went. He did have a picture there, yeah. So he is a primary care physician that works for one of the AHACs in the Southwest. He's been working with First Nations communities for about 12 years. So he came on board just shortly after I did. So we've been working with him, and he works in a, I guess, in a capacity as a like for a consultant, I guess. So we draw on his expertise to say, what about this and what about that, and how do we engage with the communities, in a respectable manner. Oh, there he is. Just try to catch up on my notes here. Yeah, there we go. So there's just a little bit more about the role that his name is Dr. Rugden Hill. So he works with what they call SOHAC. It's the Southern Ontario Aboriginal Health Access Center. So there's 3 in the LHIN, in the Southwest LHIN, and he works in the one that's right directly within the Chippewa First Nations of the Thames. And then there's a little bit more. So I'm going to just show you a quick video. My name is Chantel, and I play an important role in the cancer system. There are more Aboriginal people in Ontario than any other province in Canada. Cancer rates among First Nations, Inuit, and Métis peoples are increasing compared to the rest of the population. There are more deaths due to preventable cancers, and people are being diagnosed at later stages. For many people, the healthcare system can seem overwhelming and confusing, especially after a cancer diagnosis. Many patients experience high levels of anxiety because they have to travel outside of their community for care. Some experience financial hardships and have trouble arranging childcare or finding reliable transportation. These factors can have a drastic impact on patients' well-being. That's why my role is important. I am an Aboriginal Patient Navigator. I help patients and families navigate the cancer system. My role involves providing support at clinics, helping patients and families communicate with doctors and nurses, and working with existing language and cultural translation services. I also educate and promote the importance of cancer prevention and screening. More importantly, I help to bridge the cultural divide between healthcare providers and their Aboriginal patients and advocate on their behalf. Not only do I support Aboriginal patients and their families through their cancer journey, but I help them to cope on many levels: emotionally, mentally, physically, and spiritually. In Ontario, there is a provincial cancer strategy that recognizes the challenges faced by Aboriginal Ontarians and provides the tools and the control to create change. I am honored to be a part of this change and making a difference in the lives of First Nations, Inuit, and Métis patients and families. So this kind of just leads into that question there, you know, where I guess kind of provide a lot of the work that I do is advocacy work, and it's really just being it's actually being right alongside the patient and helping them voice any questions or concerns or issues, or even just helping them to understand some of the medical jargon and understanding their diagnosis. I haven't had anyone who's had required translation services, but I do know for a lot of the communities up north, their first language is their traditional language, so they require a lot of translation up in the northern communities. And in saying that, we do have a number of patients that come from, I guess it would be like Thunder Bay and upwards, and they're traveling from those communities like north of Thunder Bay, and they do come to the London region to be serviced for radiation. So this is a picture here of, so across all of Ontario, so there's 10 of my role, and we're located in the LHINs with the highest population of First Nations community members, First Nation, Inuit, and Métis community members. So all of their areas are kind of listed there. I work closely with the Erie St. Clair communities. A lot of their community members do come to London for services. I also work with the Hamilton Niagara branch navigator, because Wellington, I think where we are now is in the Wellington LHIN, is it? Yeah. And unfortunately, the Wellington LHIN doesn't have a navigator. So between the two of us, we kind of navigate any patients that might be identified in the system.
Palliative care is a holistic approach to active and supportive care for cancer patients and their families. As a healthcare provider, a culturally competent approach to palliative care means supporting the spiritual and cultural beliefs of your patients. When interacting with First Nations, Inuit, and Métis communities, the ability to understand, appreciate, and respond to their needs can have a substantial impact on the patient experience. Palliative care is not a common term in First Nations, Inuit, and Métis communities, so it's important to clearly explain medical terms and information to ensure the patient and their family understands. For many First Nations, Inuit, and Métis people, spirituality is a cultural expression and way of life. Some beliefs and perspectives may be helpful and comforting when coming to terms with cancer. For example, a person who is terminally ill may wish to have time with an elder, a healer, a priest, or a minister, depending on their beliefs. For others, cultural practices and customs may be important, such as the presence of extended family, smudging with sage, sweetgrass, or burning tobacco, drumming and singing, tobacco ties, cedar bath and tea, or, in some cultures, simply opening a window for their spirit to travel. It is not uncommon for First Nations, Inuit, and Métis people to feel that doctors just treat organs or the disease itself. Healthcare professionals need to convey that they are treating the whole person, and not just part of the body where the illness is present. This includes the physical, spiritual, and cultural aspects of care. Respect, privacy, and communication are essential. There is a need for seamless collaboration between oncology and palliative care teams, including the introduction of palliative care earlier in the cancer journey. When palliative care is introduced early, patients report having better control of symptoms, better satisfaction with care, and improved ability to live well. First Nations, Inuit, and Métis families are more comfortable with their loved one receiving palliative care if it's been in place all along. Cancer Care Ontario has established Aboriginal leads and Aboriginal Patient Navigators across the province to provide support and advocate for Aboriginal cancer patients and their families.
So these tools were developed in partnership with the Aboriginal Cancer Control Unit and Cancer Care Ontario. I believe it was last April, they did a needs assessment. I don't know if it was a needs assessment. It was more of a survey on palliative care needs, kind of the issues, that sort of thing for First Nations and Inuit and Métis people across Ontario. So part of the work that I did when I first started was connecting with the communities in the Southwest region to meet with them, to meet with patients, to meet with families, and really just ask them about, what does palliative care mean to them? What does it look like? So that's, I think they drew on a lot of that work that we did in those surveys with the communities, and they developed these tools for the journey for palliative care. So they are really directed for the patients. I find them to be helpful as well, though, because I always have to sometimes kind of, pull myself back on track to say, well, you question sometimes, your ability to, are you communicating effectively? Are you asking the right questions? Are you being culturally appropriate? Even as a First Nations person, it's difficult for me because sometimes I find that I just maybe, sometimes assume that someone is, maybe practices traditional medicine when in fact they don't, and they believe, another, have a different religion or tradition. Okay, so this is kind of just a pamphlet by pamphlet rundown. So the first one in your package will be, or one of them in there, one of the 6, will be understanding the diagnosis. And kind of like what I had mentioned earlier is that palliative care is an unfamiliar term. So just really helping families understand what that means. And I think someone had mentioned it earlier today in the main room that palliative care has the connotation that it's end of life when in fact really it isn't. It's about just implementing, services for people at the beginning of their diagnosis. The second pamphlet will be really like guidelines for working together. And that's just, I'm just going to pull up my notes here. So this is working together effectively with the First Nations and Inuit and Métis people in regards to their needs and their choices, and just respecting their wishes for whatever it may be for palliative care. The third pamphlet focuses on taking care of your loved one. So I believe this one is for the caregiver, and just some tips on, taking care of your loved one, making sure you take care of yourself in order to be, an effective caregiver. And the next pamphlet just talks about some of the support services in the region. So these toolkits have been handed out across all of Ontario. So it lists all of the regional cancer programs in there, and the contact names for each of your Aboriginal navigators in your areas. And then the last part just kind of really just helps, the families to understand and to, talk about their beliefs for maybe when their loved one has passed. And this slide here, this one is kind of going back to the terminology that for palliative care, for advanced care planning, for DNRs, for EDITH. A lot of that terminology is brand new to our communities. So a lot of the work that I do when I'm working with patients is really, talking about them, do they understand what a DNR is? Has anyone spoken to them about it? And addressing, because I have seen where there's been the turmoil within families on, who's making the decision here, who's in charge of the, of our loved one's health. So talking about powers of attorney, for health and for finance, those are really new avenues that and new I guess ground that we're traveling there. Because even as a nurse, when I worked in long-term care, and our long-term care building was situated in a First Nation community, so some of the patients that were coming in with their families, I knew them. And when I kind of reflect back to that role, I remember feeling how uncomfortable it was to ask, the daughter that's sitting with their mom, who has, I don't know, maybe she has chronic COPD or whatever it may be. And I remember it being right on the top of the checklist for doing the advanced care planning and doing the DNR. And I remember thinking back how uncomfortable I felt asking the family member as soon as they came in the door, have you talked about a DNR, and have you talked about the wishes of your mom when things start to deteriorate. And I think that is still applicable here for our palliative care patients in the community and in the hospitals, in terms of, I know that we need to speak about those things, but I think to be maybe a little bit more culturally appropriate is maybe if it's, if it's pulling the loved one, if the caregiver to the side, if it's the power of attorney, if it's the daughter, maybe pulling them to the side and really asking them if this is, something that you would speak about in front of if it's their mom, if it's their, if it's their family member, if it's their husband or wife. Because what I have found, and what I have heard back from patients, is that was really disrespectful for that caregiver to come in my home and tell me that my mom's going to die and this is going to happen, and that she needs to get a DNR because she's full code right now, and because of her disease process, and on and on and on. And I have heard those words come back from family members that's disrespectful to, talk about those things right away. And working with First Nations people is a lot about building relationships and building trust. And I think that goes hand in hand with that piece about talking about some of those little bit, I guess, more sensitive topics. We never want to, know or think that our loved one is going to die. And, unfortunately, I think as, our populations are, aging, and that, those conversations need to happen earlier on, because I'm having those conversations now with some of the people that I love, and say, hey, let's talk about it now. I'll talk about it with you about me, so that you'll know if something happens to me, this is my plan, or this is what I would like to happen. So I'm starting to do that with my own family members, so that it doesn't become something, you know, in the 11th hour to say, well, what are we going to do for mom? What are we going to do for dad? Or, you know, how is this going to work and who's going to make all the decisions? Because they're already so overwhelmed with the diagnosis of cancer that, you know, it just kind of amplifies everything. And so then I have the binders here too. So the pamphlets are meant to go hand in hand with the binders. So I've got 4 binders left, so you're more than welcome to have one. And you have one, right, Jim? Do you have one?
So, but we can
Yeah,
take it
I
back
can
to
get one.
support.
Okay. So you can have these. You can take it.
Okay.
Yeah, because we are getting another order in from Cancer Care Ontario. So what I've been doing is sharing them with the healthcare providers that I work with in the Southwest region. So, yeah. Oh, here, you might as well take that one, Jim. I do have one left. Okay. And all these resources are also online with Cancer Care Ontario as well, in PDF format. So I won't really go through the kit. How much time do we have? So this slide here goes back to the comments that I was making in the beginning about the end of life project that Lakehead University was doing with 4 First Nations, 3 in Ontario and 1 in Manitoba. And what they did there was they actually went right in, and I think it was a 5-year project, was it not, Millie? I think it was 5 years. And so that's just wrapping up. I don't think we're going to have enough time to show the video. But what they did was they worked with communities. Some were remote. I know that I believe 1 community or 2 communities may have been fly-in. And one was a nearby First Nations with 6 Nations, which is just not far from here, like just, we're in Stratford, right? So going towards Woodstock and then going down towards Brantford. So 6 Nations is located out there. And so part of the work that I've been doing is partnering with some of the ladies who were part of that research project in terms of, you know, I guess what their final outcome is of their whole project is developing a tool. Is it a tool book or a toolkit to help healthcare providers work with First Nations communities. So that was a 5-year project that they did, and they have what they call I believe it's a health alliance. So I did put a request into them to be part of that health alliance in partnering with those communities and the people that are on that team. And one of my good friends, she's on that team that did that research. So I feel very fortunate to be, I guess, kind of in the close-knit communities that we are, because everybody knows everybody or somebody knows somebody. And so she's been able to provide me with a lot of information in terms of how palliative care is working for 6 Nations. The one unique thing about 6 Nations community is that they have a population base of about 20,000. So what's working well for their communities may not work well for the First Nation communities in our area, because our communities are like much, much smaller. One of the communities I work with, for example, has a population of 300. So to implement, you know, palliative care services, they'd likely have to partner maybe with maybe a bordering community. And one of the other, I just thought that was, you know, like, even though they've done so well, I don't know if it really is transferable to our other communities, but it may be. We're not sure, right? And I'm just happy, I think, for the role that I've done and what I've seen for palliative care, to know that we are working towards improving the system for First Nations, Inuit, and Métis people. So there is work that's being done. And the video I think on there is about 20 minutes, so I won't show that video. It will be in the package though, and when you get the package you can click on it and you can watch the video. This is brand new from Cancer Care Ontario, so in partnership again with the Aboriginal Cancer Control Unit. They developed a e-learning modules, and I believe there's 9 modules, and it is accredited. So you do get some, I guess they're called Main Pro credits for that. And so this was just, they just launched I guess advertising it on September 10th. So it is brand new. I haven't looked at it. I don't know, Millie, have you had a chance to? I haven't looked at it at all, but it's brand new. It is in your package as well. There's a little card in there that kind of gives you an idea more about it. Oh, and this is what the card will look like here. So that was, this leads into the cultural competency. So for the e-learning modules for CCO, the Southwest LIN in partnership with SOHAC also has developed some Indigenous cultural competency training. Theirs is, I believe, is it's an 8-module training. I have taken it, and I think that it was probably one of the best history lessons that I ever had. I'm a First Nations person. I've lived here my whole life. You know, I lived in the community, you know, almost my whole life. And to kind of reflect back on the teachings that textbooks gave us, you know, as a child, and, you know, knowing that our history is passed down from generation to generation, and most of it is just like verbal, and then seeing it actually in writing and confirming all of the stories that we've ever shared in our families, and then actually seeing it on paper and showing the history of First Nations people in Canada, and kind of where you know, the beginning of, you know, I guess contact to today, and the health, I guess the kind of the health status that First Nations people are really in today. And it gives you I guess a quick overview of kind of, you know, putting all of those perspectives into how First Nations people view the health system. It shows you some history on the history of the Indian hospitals back in, I'm going to say it was the late 1800s. So one patient story that I was shared, a patient shared with me, was that she went into the hospital, I believe when she was, I think she was around 14 for TB, and this was in BC, and when she came out of the hospital, it was like 7 years later. And that's, you know, I don't know, to me, I was a little bit kind of like surprised by that. I thought, like, who stays in the hospital for 7 years? But those are some of the historical pieces that go along with First Nations people, and kind of like where we've come and where we are today. So there's a link there, but we're not going to have enough time for that one either. And through the work that I've been doing as the navigator, I've been able to partner with the Southwest LIN. So they have a Aboriginal committee which comprises all of the First Nation communities in the Southwest LIN. So I sit at that table to just kind of, I guess, contribute to the discussions about improving palliative care for First Nations people. And part of that, I guess my contribution comes from also sitting at what they call the Hospice Palliative Care Collaborative. It's the London Middlesex Elgin Collaborative, London Middlesex Collaborative. So that table really is people from different, like long-term care. So there's executive directors, there's people from hospital, there's palliative care doctors. So there's about, I think there was about 20 or 30 that sit at that table. So I sit at that table with them, and we also discuss you know, palliative care challenges and opportunities for improvement. And I think I already mentioned the End of Life Care in the First Nation Communities Alliance. That's with the Lakehead research project. So the patient navigators as well across all of Ontario, there's 10 of us, so we meet monthly to just talk about some of the activities, some of the challenges, and some of the opportunities. And last year we were asked by Pallium Canada. They're in the process of developing LEAP, or I guess revising it to include an Aboriginal component for palliative care. So as part of that table as well, to help to just provide some information on, I guess, what would be culturally appropriate LEAP. That is still in the works. I'm not sure where it is right now, if it's completed. And then this picture, this one here, just gives you just a kind of a overview of where the communities are, their names, and the other affiliations that I work with is the friendship centers that are urban centers. and then working closely with the health access centers. And this just gives you a, I guess, kind of like a physical location so you can see where the communities are. So a lot of the work that I do is in the Southwest region, and she's just giving me a time's up, so I'm almost done. And so you'll see that there's there's 5 communities in the in the north. We have a patient navigator through SOHAC that I work with closely so that we can make sure that we address those communities up in the north. And then there's just some cancer screening in your packages as well. And then that just kind of goes into the Cancer Care Ontario's priorities. And that's it.